Okay, let's kick off with the second half of this morning. A very warm welcome to our second set of volunteers who've come to testify. So let's start with a round of introductions. I'm Andrew Ridley. I will explain this time because some of you might even know what they are. I'm a Managing Director of a Commissioning Support Unit. That's probably all you need to know about me. Let's go.
Jeremy Taylor from National Voices, which is a national umbrella organisation for health charities.
Gillian Greenough, I'm Chair of Islington CCG and a GP.
Pat Callahan, Councillor and Chair of Camden's Health and Wellbeing Board.
William Roberts, Director for Strategy and Planning at Camden CCG.
Rosemary Westbrook, Director of Housing and Adult Social Care for Camden.
Sarah Dugan, Assistant Director of Public Health, Islington and Camden Councils.
Martin Elliott, I'm one of the medical directors at Great Ormond Street.
I'm David Sloman, I'm Chief Executive of the Royal Free London NHS Foundation Trust.
I'm Sue Pritchard, I'm a looked after children's nurse in Camden.
I'm Robert Erica, I'm from Pharmacy Voice, which is a collaboration of pharmacy sector organisations nationally.
I'm Melanie Hingarani, I'm a consultant ophthalmologist and a clinical director of Moorfields.
I'm Greg Battle, I'm Medical Director for Integrated Care at Whittington Health and a GP in Islington.
Ron Kerr, Chief Executive of Guys St Thomas's and also Chairman of Southwark Lambeth Integrated Care.
Great, thank you very much, and I'm enormously grateful for you all giving up your precious time on a Monday morning to come and talk to us. Gillian and Pat, I wonder if we might start with you. Gillian, you mentioned you're an integrated care pioneer.
Yes, yeah.
I know you've got a strong vision. Is there anything you would want to tell us about that? We'd like to focus the discussion on quality of care and integration of care, and also picking up anything that we've heard from people we've heard from already this morning.
Yes, well, I think it's been absolutely fascinating listening to people. And again, I'd like to echo that actually, as a first year of a clinical commissioning group, it's actually felt quite exciting, the change in terms of we've been very keen to work together a lot more closely than we have in the past. So there's a strong history in Islington of working closely with the local authorities. We have masses and masses of shared budgets, which has always worked well for both of us in that if there are any cuts in the system, we try to minimise the impact across the community. But actually, it's much, much more positive than that. And I think we kind of set out this year to say, actually, we know that it's a time of change, but let's try and make things better and higher quality for patients, and ask people what they value and what kind of outcomes they want to see. And we've worked very closely with the local authority and with our local hospitals. Greg's here from the Whittington, which is an integrated care organisation where we've got all our community staff are under them, and I think we've seen real change. The GPs are really very, very involved. Public health are very involved, and we've actually seen things happen at a level that we wouldn't before. So kind of from great big public health programmes and which involves the local authority and everybody in that system, we've actually turned around the heart death rate under 75 when we weren't actually expecting to see a change, so quickly. But I think the things that struck me about some of the speakers already is with the local authority, we're very much wanting to get back to a sense of community. There's the whole infrastructure of local business. How can we get everybody in our local community using local businesses, using local shops? We had an air pollution conference recently, and what they were telling us was, if you just get off your bus a stop earlier, actually you can do more for your health and for the health of people in London than virtually anything else. So how do we kind of tie in everybody to looking after their community? And it was so interesting to hear about people who are working, helping out their neighbours, and community centres helping out their local community. I think getting that sense back of all being in it together and all knowing how it works is incredibly important. we're doing a lot of things with our navigators, like we said, which is about, we realise that every GP has to remember about 6,000 or 7,000 different links into the things in the community, and sometimes they don't get used just simply because they're not at the front of your mind. And the idea of our navigators is that if somebody is needing help, is it that the first thing they need is help with their benefits because, a spare bedroom tax or something like that, or would they actually like help in a different way at the local community centre? And the idea of the navigators is that they're very aware of everything that's going on and can kind of personalise it to people rather than it, like somebody said, rather than it being the same for everybody.
So I take it from that, apart from being a pioneer, you're an optimist around integration, and you think the current structure is helping you to reconnect with local authority. I know you've always been very well connected with local authority, but through them with the community.
I'm a real optimist about working with local authority and local providers. I must admit, and patients. I think the patients are the most important bit of it. But actually, working together, you actually see where things aren't working properly, and I think that's been where we've had most success, really.
Fantastic. Pat, I wonder if you might want to come up from a local authority perspective.
Yeah. Like Gillian, in Camden, we've been joint commissioning services for years, and it works well, and I think we work well with our CCG, and we're very lucky to have two brilliant chairs in Camden and Islington. And that's very lucky. And William here, we work together well, don't we? But I'm going to go on a different experience, and experience is definitely the word in this case. We looked at our budgets, which were shrinking and will shrink even further, and we had I think it was 6 centres for people with older people with mental health issues, dementia and Alzheimer's. We had a lovely centre for people with mental health issues. It was state of the art. We didn't have a centre for independent living. We had a centre for people with learning disabilities. And looking at these centres, they were very old, took a lot of maintenance, utility bills, etc. And we thought, they're not fit for purpose, they're not good, how can we do this differently? And the officers came up with an idea that they put to me, that we had a tranche of land, which is very near the Forum in Kentish Town, and couldn't we have these 5 centres with their own separate access, but have a centre for independent living which they could go in and out of. They didn't have to mix, they could mix, and we would love them to mix, but they didn't have to. And I can't tell you the fury that was unleashed when we posited this. And as a councillor, I believed in it. I thought this is the way forward. The centres that we've got now are going to fall down round their ears, and we're not going to be able to maintain them. And they don't have the latest and greatest stuff for people who are vulnerable or who have disabilities, and that's what we want. Good quality services for all our people. And we had 41 consultation meetings. It was, at times, Rosemary will attest to it, it was horrific, but we believed in it. We believed we were doing the right thing. And a lot of the time we saw that the people who stood to lose, i.e. the people at the top who were running these centres and who didn't want to go into a much more holistic way of working, were the ones who were encouraging the service users not to go along with this. Eventually, because of co-production, we're working with 368 service users to design this centre. And one of the women who's got learning disabilities, Mo, who was so totally against it, now comes up and says, it's brilliant, when are we going to move in there? I want to work with the community on this. Even other service providers and people, people who had been counsellors for years and did work in the adult social care service said, this is not going to work. And I said, well, what choice do we have? It's got to work, and we're going to make it work. And now, most of these 300 and odd people are just itching to get in there. And because we've been trying to get a centre for independent living for 20 years, we can now offer that. But it wasn't easy. It was actually working with people to say, this can happen. It's a reality. We've got 2 choices as a council. We let the services you've got now fall down around your ears, and you're going to be sitting at home all day looking at the walls. That's not what we want for people who in the future have disabilities or are very vulnerable. We want this to work. So at the moment it should be open in early 2015. And we're going to have a state-of-the-art centre with a juice bar, because people with disabilities sometimes don't use social outlets, and we want something for them. The deaf community have said they want a pub in there, so we're looking at that. We want to provide, because people who are deaf who go into a pub and their speech is very guttural. A bouncer or somebody who's behind the bar serving them might think they're being very uncooperative, and a lot of them have said they're chucked out of pubs and clubs, etc. We don't want that for our deaf people in Camden. We want to give them a home somewhere. So it's ongoing and it will be successful.
Thank you. That's a really significant story about really significant integration and service change, but in a really tough climate. Jeremy, I wonder.
Can I just sort of gently challenge you on the question of co-production? Because in one sense that's a very powerful story about working with service users to design a new service. But on the other hand, it's also a story of the council saying, you will not have the services you used to have, however much you are attached to them, sorry.
Yeah.
And that wasn't co-production, was it? That was you saying, this is the new reality, you're going to have to live with it.
Yeah.
So to what extent could there have been a different way of doing this, which was to say, here are 5 valuable services that people, presumably the service users, valued? Is there another way of maintaining them? So you didn't have the conversation at that point, it seems.
Officers had conversations, but what we would have had to have done is to have got businesses to sponsor those buildings. And there is one of those services which is working with the community, and I hope businesses, so far nobody's come along to sponsor them. That's the People's Community in Shoot Up Hill, because they want to stay within their 2 houses, but we know that we don't have the money to maintain those 2 houses, and they haven't got the latest technology, etc., but they love it. So, for them, they feel that that's where they want to be. So, yes, we could have spent a lot of time going out to businesses and seeing if they would join with us in, developing other services, but we didn't have much success there. So, yes, you're right. It was a case of, this is what, as a responsible local authority, we're going to have to do. And it did bring up the difficulties at the beginning, because people love their services. They love buildings, people, because it's a security blanket, isn't it, a building? So, but it's something as a responsible council we felt we had to do. But in the beginning, very difficult.
Yeah. One of the things that I'm thinking that links to the previous discussion was the role of the voluntary sector and community groups. And we know that in the kind of debate about the future of things like libraries and leisure centres, there's a lot of thought in local government about how you can hand over community assets to other parts of the community. I just wonder whether, it's a kind of theme for this discussion for me, because you can have a conversation about integration that's all about public services and statutory agencies and miss out the community sector. Could this have been done differently if there'd been a different conversation at the outset involving community groups?
The thing that's missing there is the money to provide the services. We're running a community library in Primrose Hill, but some of the people there have donated $10,000 a year to run that. Now, if you're within communities that don't have a lot of money within them, you're not going to have the money to run those services. Yes, we could have worked with other community services, and we are working with a lot of people up in Kentish Town, the Kentish Town Community Centre, etc. But you have to have finance to run a service, and that's the big issue. That's the elephant in the room, actually. So it's a very difficult one.
Can I understand the financial context, of course, because it's true across the whole public sector, isn't it? I know it's especially acute in local authorities. But do you think this service change would have happened without that financial context? And do you think it's the right thing to do regardless of the financial context? to move to a different model of care and profoundly more integrated services?
Perhaps I could just add to
Yes.
that. I mean, I think there's a general direction of travel, isn't there, to different models of service, and effectively as sort of next generation of service users coming forward, they don't always want to have a service that's delivered in a particular building with a particular other set of people. And very much of what the personalisation agenda has done in social care is actually start to design services around individual needs, rather than saying, because you have this need, this is the service you get. And I think this proposal was very much in moving in that direction. We had some specifics about some buildings that frankly weren't fit for purpose anymore in terms of accessibility and maintenance costs and all of that, and actually designing and co-designing a new service was part of the direction of travel. But I think beyond that, we are starting much more. I mean, I think this is not a Camden specific, it is the direction of travel in adult social care, and I think increasingly in health, about actually starting with person-centred, patient-centred services. And that does mean sort of rethinking the design, and not always focusing on the buildings, but focusing on the services that we wrap around, or sometimes not the services, sometimes talking to people about what is it that is the issue. And we talked earlier, and it was very interesting, picking up the issues around social isolation, understanding that that's an issue for people. It may not be about a service, it may much more be about connecting people into what's going on in the voluntary sector in their community, and actually using the sort of the assets we have in communities, using everything, so that we can then focus what's left in terms of much more limited public sector spending on, if you like, the more extreme end of need. But we've got to do some work, I think, to support communities, and all of the things that we talked about in the first session, to make sure that where we have got public funding and we're putting in money, we're doing it with that in view, about self-reliance, building confidence, all of those sorts of things.
Gillian, do you want to come on this point?
I think it's kind of difficult to go back and look at something that's happened. I think Camden, because I'm from Islington, but I imagine Camden's got a lot of the same problems as Islington, that with being in the centre of the city, actually premises, although we don't want to build things around premises do become a problem because it's so expensive, because kind of landlords and people like that are always after the buildings. But I think I think the personalisation agenda that you brought up is so incredibly important. We're certainly doing a lot towards personalising care. Giving somebody a bit more control over how they use their services. So we've got somebody whose carer takes her along to Arsenal every week. And that's part of her personalisation budget, because she's got a carer. Why not be with your carer at Arsenal rather than with your carer sat in your sitting room? So there's something about encouraging what people are passionate about and what they want to do, and it's not always around buildings. I think what we see as GPs, though, is that actually communities in London are really, really small. So I come from Stockport, just outside Manchester. And that was a smallish village that had a community. But actually, I've never seen anything like what it is in London, where if somebody has to travel half a mile, they consider that outside their community. I had to travel 10 miles to school when I was younger. But the thing is, the reality is that is what London's like. And, there's quite a lot of social isolation in London, but actually it's therefore important to value people's local little community, because that's where their friends are, that's where the people are that help them. And sometimes, kind of getting somebody to travel miles, half a mile, means that they're not in contact with their local community. So I think it's different for everybody. I think we would like to hope, we've tried to concentrate in Islington on, in terms of health, making the children's centre and the local GP the centres for all of that kind of healthcare. So it doesn't mean that your children's centre is the main one or your GP is the main one, because the buildings might be different sizes and you might not be able to put the services, but linking the two together so that we both give each other's messages You know, kind of we've tried to make that the focus of their healthcare, but I think it's incredibly important to preserve that local community where it's easy to get there by transport. You know, sometimes across Islington it's only 4.5 miles long, but it can take you an hour and 10 minutes to get to the top of the borough. And you know, you can't do that if you're going socialising every day. So I think the diversity of London in terms of little communities, you know, kind of everywhere we've got to look at it as what's useful locally.
Thank you. So, I mean, this is really quite powerful stories about local integration, the importance of the practice, the children's centre, the local authority, community groups, and people's neighbourhoods, really, in what we think of as a big global city, but actually is a series of interconnected neighbourhoods, isn't it? We've got some very big providers here, though, specialist providers and national voices, and now I just wonder, we might hear about integration from your perspective, which is slightly bigger scale than some of the level we've been talking about just now.
So if I just build and reflect on what I've heard, I too am a believer. I really do believe in integrated care. I think it's actually about transforming whole systems of care rather than integrated care, which is what we're hearing here. So there's something about thinking about how we place ourselves there. I also think it takes time. And one thing we shouldn't underestimate the amount of time it does take to work these things through, because I totally agree with what's been said. It is about co-production and it is about local flexibility, and lots of the things we heard this morning I would absolutely reflect back into this debate. I also think we do need to be aware of, I think what I've heard described previously as the tyranny of innovation. You know, this year we'll be doing this, and then the year after that we'll be doing something else. It's a long haul, actually, and we do need to be in it for the long haul. There's something about how we align incentives, about the clinical incentives and the financial incentives aren't totally aligned, I think, at the moment to drive maximum value out of the system. There's a piece of work there. And the final thing I would reflect on what I've heard here, I think Camden were very, very brave, actually, in setting out a manifesto for change, saying what we've got currently isn't sustainable given the challenges that we're facing. A very brave campaign, I thought, on the bus shelters, which I noticed at the time, saying the money's really tough. We've got some tough choices to make. Things are going to be different. We want to engage you in that debate. And I think, for me, one of the things the London Health Commission can do is set that big change context to something inevitable that everybody around this table and in the audience are going to be involved in over the next few years. So it's that mandate for change, I think, is critical.
Martin, did you want to comment?
I do. Great Ormond Street's in a weird position because it's a highly specialist organisation, but in this context it has an additional advantage in that it's dealing with every community in London, and indeed every community in the United Kingdom. And I'd like to make a couple of points. The first is that there is massive variation about what the definition of a community is, and there's massive variation about how easy they are to relate to if you're a provider organisation. The new reorganisations within the health service have far from simplified that relationship. They've made it much more complicated. And the bureaucracy associated with it has a detrimental effect on the flow of patients from a highly specialised service out into the community. There's a moral argument as well about the stuff that we're doing and other specialist services are doing, which is both internally and externally driven to do more and more difficult stuff, which means we're generating, in our context, more children who will end up needing SUS care in the community. And the patchiness of those services around the country and the way that they're funded, even from the voluntary sector, means that as a provider you can't make that integrated care that you were just talking about, which is absolutely vital if you believe in value is outcome divided by cost. We can't deliver that in a way that we want to. The final point I'd make is that in the end, all of this is about the information. We heard a lot this morning about the argument between anecdote and absolute information evidence. But I would argue that if we're going to get this just right, both sides of the equation, the community and the providers, have to publish their quality data transparently, have to observe the path of a particular patient, and find ways of sharing data which allow us to track variance and improve the quality of care that we make. Otherwise, we're all just talking about opinion and not being able to deliver fact over time.
You've touched on two issues which I know are perceived as especially problematic at the moment: the separation of specialised services the structures that we've put in place, I think most people regard as profoundly unhelpful, and then the current information governance problems we've got and some of the sensitivities around data makes it more difficult to flow data across the system than it ever has, most of which, of course, is for the benefit of patients. Martin, what do you think the Commission could helpfully recommend that would help resolve some of these?
Yeah, it's a really hard question. I mean, you obviously don't have power over some of the key elements here, which is how you finance some of the data flow, which I think is the big challenge. Most of the market is handled by big American companies who manage enormous costs for provider trust, some hundreds of millions, up to hundreds of millions, 250 million in Adam Brooks, I think, to deliver an IT system. And it's not integrated with anything else. So there are basic, we've got EPS, which is a big improvement over just a few years ago in delivering prescriptions within general practice and pharmacies. But for God's sake, some influence ought to come from the Commission to say, yes, Connecting for Health failed, but let's look at other ways. There's been big changes in gov.uk to get out of the control of the American companies, to use open source software, to develop much more sophisticated web-based searching tools. But none of these people will touch the NHS because it's just too complicated. So I think we need to ask for your influence to say that even if it's only a London-based solution, a standards-based approach to how we interchange data, even if you don't do anything, is what's needed.
So we're not yet alighted upon this. You won't be surprised to know, I suspect we will steer away from a London solution, anything involving technology, but we may well make quite some strong recommendations around interoperability and expectations of providers and commissioners around whatever system you're buying. It has to do the following things, and then whether we go a different level in terms of making that more accessible, like TfL has, for the benefit of app developers.
There's one final solution, that in the absence of being able to bridge ourselves together, because I work with children and all their parents are young, and we have over 95% of them of those families own a smartphone. Those children and their families can actually act as the carriers of the data. You don't need to interoperability all of it if their data can live on their device, on our server, and we can share it with a GP in another part of the country. So we have to trust the community and the patients as the core of that community to be able to distribute the information.
I think I've seen some fantastic technology actually. It was developed by one of the parents of who lived in your hospital, and he was there for so long. He developed your IT.
There are many others like that.
Yeah, absolutely inspirational parent he was. Let's continue to pursue that. I want to hear from more fields, but let's Sarah first and then William.
It was just on the information as well from the commissioning side and public health. I mean, all the changes within the NHS have had a massive impact on what data we can use for planning and evidencing any outcomes. And I think this is having a detrimental effect on what we're going to, or putting in the evidence for what we should be changing to integrate care, and then also measuring what the impact of that is. And I think it'd be good if the Commission could take up the information governance aspects at a national level.
Is that because you find access to NHS data now considerably harder now that you're embedded within the local authority?
Some of it's just stopped flowing within the NHS itself, and then some of it is now we're in the local authority. There's also there are different messages coming from NHS England and then the Department of Health as well about what you're allowed to do. And there's a lot of confusion generally about what the rules around information governance are. And I think it's a really big barrier to doing this type of work.
I couldn't agree more. I was struck by when Pat was talking about the interaction you'd have with your community. We've kind of got the same on a national scale, haven't we? It's poorly understood by the media. There's lots of ill-informed speculation around it, but actually some of the things that are happening behind the scenes are profoundly damaging to our ability to design and build better services in the interest of patients. We're not really interested in selling data, we're interested in understanding what people's needs are and how they're using it.
But if we want to actually integrate health and social care, we should be linking up our health data with the social care data, obviously within the bounds of information governance and patient confidentiality, but we're unable to do that. So we're just, guessing where where we should be making changes and not doing it on the hard evidence.
It's currently very difficult to link it up inside the NHS, isn't it?
Yes, yeah.
William.
So I think there's two things. One which obviously relates to this, which is just that we've done our integrated digital record. It's now being used in both our major hospitals with all of our GPs, with our community providers and with the council. It's used in clinics to help inform. It has a single front end. It's linked the system together. It wasn't expensive and it wasn't a major IT problem. It didn't cost us £250 million. But the challenge with that is it's local. And there's an inherent tension in the system between doing things locally and making it relevant to people who come to centres like this. Bear in mind, most of us will never come back here. Some of us will, fortunately, but most people will never come back here. But for these people, they still live here, breathe here. So me talking about, a national programme is meaningless. But equally, how do I make something that we've done in Camden applicable to a much bigger area? Because there's no point in Camden for somebody like, even Great Ormond Street, but take Royal Free or UCLH, who have hundreds of other customers from other parts of the world other than us. The second thing I think, which we probably haven't made enough of in the NHS, is everyday technology. And I'm not talking about us going off and building, mega apps and setting up our own programme to reinvent the wheel again. But actually, my mum and dad talk to me every night on Skype. They talk to my children on Skype. Yet this morning I had to be on a phone at exactly 8 o'clock to speak to a GP receptionist to get an appointment. That's pretty old school. I went on, tried to look how I'd get myself electronically registered at my GP. I have to go into the practice to ask them to register me in case I'm not the person I say I am. We really are lagging behind in terms of everyday technology. I've got children who know more about how to use IT than I do. My youngest one at 5 is more IT literate than I am, and I think there is something about how we use everyday technology. You don't have to be in front of people. And one of the things about London, it's condensed and people don't think it's big geography. You go to somewhere like Scotland, community nurses have been using voice over internet protocol for years because it's too far for them to travel every day. Yet in London, couldn't possibly work, and somebody tells me why London's different to the rest of the world. And I think there is something about how we just pragmatically find simple solutions rather than finding the most complicated solution to what are really difficult things to do. These things are hard enough without us making it harder.
Thanks. We'll perhaps come back to more modern models of primary care if we get time. David, did you want to come in on this point?
I just wanted to say I think the issue about the technology at one level is important and at one level doesn't matter. Someday it might be an iPhone operating out of cloud or somewhere. The real issue is how we organise the data in a way which enables clinicians and practitioners to get together in the interest of improving services, and that's where I think the real focus needs to be. I do come back and thought it was the right answer about what the Health Commission could do to help. Cutting through some of the information governance stuff would be really helpful, both within the service and across the sector. I think it's something which is very practically could be done. And there's also something about making sure that we don't allow the best to be the enemy of the good. I do think we've got on with it. Now, we haven't solved all the problems, but we're 7 out of 10, if you like, and it's not losing sight of that.
My chair wouldn't let us do anything but get on with it.
Yeah.
I mean, that's the thing, is it wasn't an option to be perfect, it was get it done because the people need it.
A really strong message around information flows and RG and data. I want to hear from Melanie kind of about Moorfields and then Greg locally what it feels like at a local trust.
I was just going to make a bit of a broader point, not particularly Moorfields, but I think that one of the things that I wonder if the Health Commission could do is more broadly than just exchanging confidential information is actually to get some meaningful conversations going across boundary, because I think I work in Cambridgeshire and Bedford and also in London. And you can really sort of contrast the non-London areas. I think particularly when I started, I'm just a simple consultant clinician, and I want to talk to people in social care. For me, I do children and see adults with learning disabilities, so I need to speak to the sensory support teachers and all these people kind of out there in the community. And when I first started, I had no idea who they were, where to go and how to talk to them. And in Bedford and Cambridgeshire, it wasn't too difficult to find them in the end. We were local to them, they were local to us. They were absolutely delighted that someone from the hospital actually ever wanted to speak to them at all. But trying to do that in London, oh my God, you kind of don't know where to start. And also it does become difficult because, like with Great Ormond Street, our catchment area is kind of the nation and certainly London. So then we have to have relationships with an enormous number of people, but whether there's some way in which the Health Commission could set up something and facilitate those conversations so that we do know who to go to, have those conversations, who these people are, and also as people change the perception, certainly for us, is I think it was a comment earlier, wasn't there, that, you know, the Royal Free and that, you know, the big hospitals have been there forever, but everything out there in the commissioning landscape seems to change all the time. So just when we found the right person to talk to, ooh, they've gone. And then there's another year to find the next person. And I think the other sort of barrier, which somehow we need to get over to have these conversations, is that, you know, adversarial nature sometimes in the way the commissioning is now run between the kind of us and them, because many of the conversations are around commissioning, tight money. You, the hospital, you obviously want to charge us loads of money because you don't want to let any of the patients go out into primary care because you'll lose your income. We need to be able to have a conversation, parking that to one side, and talk, you know, meaningfully about how we can run the whole thing right across all boundaries.
I support the arguments about the relationship with the commissioners. I think we both deal with specialist commissioning rather than CCGs, but it has become quite adversarial and of massively varying quality from month to month.
Why has it become adversarial? What's changed?
It's bottom line sensitive. It's very simple.
It's hugely overspent. That's why.
Yeah.
It's putting everybody under a lot of stress.
Prior to the announcement of the overspend, the bottom line debate has been going on for a while.
It has indeed.
And the difficulty, I think there's a difficulty around integration, that it isn't going to be achieved except through iteration. It is going to be impossible to set out an outcome-based specification which is meaningful without an engagement with the provider who can influence that and then change the commissioning specification the following year so that you develop it. And that's why I think anything which is adversarial, as distinct from focused from different perspectives, is quite difficult, I think, to deal with.
One of my madder moments, I thought it would be more interesting if commissioners bought the information, because healthcare is fundamentally an information economy, and if they actually knew in detail what the pathway and consequences of the treatment that we did were, it might change the way everyone behaves. But I mean, the commissioning framework is just not sophisticated enough at the moment to be able to do that.
And I think it also sours, I think to a certain extent, what people believe, are you honestly telling the truth? So when you do have discussions regarding where provision, I mean, it could be given for us, a lot of it's about, say, whether community optometrists can deliver what's been traditionally medical care, and then there'll be some conversations regarding, is this safe? Is this going to be high quality? And, you know, if the secondary provider kind of starts to say, well, you know, we're not too sure about that, there's the sort of instant assumption, well, you're just saying that because you want the work, you want the money, whereas actually it can be a genuine concern. And again, we need to learn how to somehow work around that, and having decent outcome measures and data, I think, allows us to address some of that.
Okay.
Lots of people, I won't say much about the IT and information because I think most people have said what we need to say about that. There's a couple of things that out of the discussion from earlier. One was what you said, William, about the voluntary sector. And as Whittington Health is an organisation with an acute hospital and provides the community service for two boroughs, Haringey and Islington. So, compared to your trust, it's got a fairly defined geographical template. And I don't think we hear much from the voluntary sector, and we are sort of led by commissioners. And I think it's interesting to the commissioner recommendation around all providers looking at and reviewing their relationship with their local voluntary sector, because I think there's a whole, you could pick every department, paediatrics, geriatrics, women's health, etc., and ask what is your relationship, how do you work and lever the community, because it's enormous. The voluntary sector is rich, full of enthusiasm, vigour, and the people we've heard around the table this morning. I just think from being working on the board of an acute trust for a couple of years, that it isn't a voice I hear very often, or a voice that I hear that is seen as one that we can do business with. It's more that you, as the commissioner, will say, well, we might commission this from you, and we might commission it from Age UK, and we might commission it from someone. So I'm really interested in that dynamic, and I don't think it's going on enough. I think the issue around localities, which was mentioned a lot earlier, I'm fairly passionate about that in the sense that I think we have postcodes for a reason. The reason we have postcodes is because places are different. Hampstead is quite different to Tollington, and so that people make different decisions. The pattern of services are different. The choices of investment are different. It will ever be and will always be. Whilst there is variation that we need to be mindful, which is around quality, there will be differences in structure. We as providers have to take that on board. I know it's easier for Whittington Health. 85% of our business comes from 2 boroughs. But the larger organisations, the specialist care, where you're dealing with 20, 30, I have heard in the past, well, what can we do? We deal with so many people, we have to decide what happens. So I think that, in a way, if you deal with lots and lots of communities, it's the responsibility of the large providers to recognise that and therefore respond in a way that is sensitive to that. So that was one thing. And then the other thing I wanted to say, yes, about the tension, the rhetoric of the market, which sort of underpins and is often silent in these discussions, because when we talk about integration, when we talk about working between organisations, then the language of competition doesn't fit very comfortably with those kind of discussions. And also, I would say the language of choice doesn't fit very comfortably. Most of my patients want high-quality services on a bus route that they've heard of, that is reasonably easily accessible. And in my 20 years, I don't think I can remember maybe twice people asking about MRSA rates or Clostridium difficile or complication rates. People want high-quality services delivered by their local service. And the idea, having come from being involved in commissioning before and now on this side, the idea that consultants are gaming the system. Your finance directors might dream that they would know as much about the money that they could have any idea about gaming the system. But the vast majority of people on both sides of that particular divide are focused on and are able to be constantly refocused on the needs of the patient, which and the needs of the local population, which we have to, I think one of the problems with our market is it's a fake market. There are lots of the incentives are not real. Lots of the sort of finance structure in the end doesn't behave like a market. So there's a clash between that. And I think London, the Health Commission, I would say again, it's a kind of, and that's politically problematic, is to trumping integration, which is basically high quality care in a complex system, against and being mindful of some of the impact of the local recent changes and indeed the marketisation of at least the language, if not the reality of the landscape. So I think that's something that's important for all of us.
Thank you. Very briefly, because time unfortunately has galloped on. It's been a fascinating morning. Gillian.
I would echo what everyone said about the devices nature of some of the separations of services, and I think in Islington we are trying hard to reverse that and to try and join it up now, because actually it just doesn't work when we're all separate. And I think it's very, very important that everybody supports, kind of the way forward of payments being a bit different and based on outcomes, and supports that kind of thing. I mean, certainly with the specialist commissioning, I'm glad to hear that we're going to be involved in that now. A simple example in Islington was just Sarah, you remember when we started it a few years ago, we started painting children's teeth to protect them from decay, because we had such massive high admissions for general anaesthetic of children with their teeth. And now tooth decay has now turned around completely, but of course if there was any benefit in terms of how much that cost in terms of general anaesthetics, it's not now linked to that prevention, so we wouldn't now be able to use that money that was saved on anaesthetics to kind of help people with diet and that kind of thing, because the system isn't joined up anymore. And I think also like our work on some respiratory disease with the Whittington, where we've tackled, kind of with the local authority, we've tackled smoking across the patch. We've, our GPs kind of identify people who might be at risk. And over the last couple of years, we've had a 16% reduction in people who need to be admitted with that respiratory disease. And we've gone from being one of the highest levels of emergency admissions overall to being plumb average. And actually, it's so lovely to be average for something. So I think there's some really, really fantastic opportunities there. And it'd be really good to kind of learn from everyone's best practice, really.
Thank you. Robert.
Just very briefly, from a pharmacy perspective, I mean, a number of the conversations resonate a lot with me, particularly if you were to start, and as Sue said, we need to just watch where people go. If you watch where people go across London, then there'll be about up to 100 million contacts with one of the 1,750 network of pharmacies across the capital. We've had some really good areas which have worked very much against the grain in the past, like City and Hackney, Lambeth and Southwark were kind of leading edge. The reorganisation has kind of destroyed a hell of a lot of that. So I think we're now just picking some of that up again and starting to, as somebody also said, remake some of the good relationships that existed before. Now you've got a whole series of other structures. And as far as pharmacy services are concerned, we're also we're looking at public health going into local authorities. A good thing that is, but that means we've got to face two different ways. We've got NHS London, who actually are quite, it seems to me, in terms of pharmacy, looking at the rest of the country, quite a go-ahead in thinking about how they might at least look at the capital as a patch, as opposed to lots of different elements. But we've also got potentially clinical commissioning groups that may want to think about how pharmacy services might also be part of that overall picture. If I was to ask the Commission what could it do to help us along, I think we have had a national contracting model for as long as the NHS has been in existence, and organisations which have been very much wedded to that way of thinking. That means that at a local level and on the ground, the responsiveness of the pharmacy organisations is patchy. There are some really good ones in London, there are some not so good ones. It's fair to say, I think only at this stage are the organisations themselves starting to think a little bit more about London as an entity, and as a national group. I do sit on a thing called Pharmacy London. We are desperately encouraging them to come together. Anything that the Commission can do to encourage that development, to share experience, identify good practice wherever that is, and then be in a better position to bring that good practice to CCG colleagues or local authority people, then if the Commission can nudge us in that direction, that would be extremely welcome.
Okay, good. I'm mindful that we've got a group of enormously senior people here, and I'm sure you've got busy diaries, so I should respect your time and make sure we finish on time. I think we have heard some really clear messages, I think, in this session. Optimism about integration at a local level. It feels as though there's a real energy, and I certainly recognise that from many of the patches that we work with. A new, fresh set of relationships between local authority, local communities and CCGs. I think that's great. But we have to acknowledge that in the new system we've got, I think, real problems with connectivity of specialists, which is a big issue for the London Specialist Trust. For data flow across the system has never been so challenging and fragmented. We've got IT challenges. The incentives don't quite align up. We've now got huge separation between commissioning and commissioning behaviours, and therefore providers are experiencing quite difficult things, and this kind of fragmentation of commissioning at a local level, we need to come back. We haven't even had time to come back to your challenge, William, about why you couldn't Skype your doctor at 8 o'clock this morning. Dare I be very controversial and say why you couldn't Skype them at 6 o'clock last night, actually, or whether we should be looking at new and more innovative models of care for London's population around primary care, but that will have to wait through some other time. Ron, is there anything you would like to say?
No, I think it's been really helpful. The one thing I thought might be discussed around the integrated care and about London in particular is workforce, and the need for a workforce which is amphibious is a term I've heard used, that can move across boundaries between primary and secondary care, between community and hospital settings, and obviously the issue of recruitment and retention of that workforce in London as it becomes a more stretched financial environment.
And they're big issues, aren't they? They feature in the enablers work stream, the importance of workforce and the challenge to us long term around that. Jeremy, would you like to?
Likewise, we haven't talked about housing today, but I think that probably just reflects the mix of people and their organisations and interests. But we have talked about housing in other parts of the Commission's deliberations, and I think it will feature as a theme to take forward. But no, nothing to add. Thank you very much for a really interesting discussion.
Can I conclude by, on behalf of the Commission, thanking each and every one of you for your time. It's been an absolutely fascinating morning. I wish we could spend the whole day. I wish all Mondays were as interesting as this. As I'm sure you will. Maybe we should meet every Monday and just do this. It'd be quite nice. Thank you very much. In true Department of Health style, even though I don't work for them and probably never will, I need to tell you that an initial report will emerge in the summer and a final report in the autumn. So watch this space, and thank you very much.
Good to see you.
Thank you.